Okay, let's face it. Studying complex organ systems, especially the kidneys, can feel uh, pretty overwhelming sometimes. That sheer volume of information.
It really can. Those tiny organs do so much.
Exactly. So today we're taking a shortcut. Think of this deep dive as your focused guide to the essential concepts of kidney disorders. We're really going to zero in on elimination, fluid balance, and maybe surprisingly, immunity.
Yeah, we're aiming to break down the core content you'd find in, say, Chapter 62 of a major med-surg text. We'll hit the key diseases, from infections to trauma, looking at the why, the pathophysiology, the symptoms, and crucially, the nursing priorities.
And the central theme, the main concept we keep coming back to today, is elimination.
That's the core, but it's tied directly into fluid and electrolyte balance, acid-base balance, immunity, and of course pain. Because when kidney function is impaired, it's not just about urine. The effects ripple through every single body system. Wastes build up, homeostasis just fails.
So let's quickly define a few key terms we'll be throwing around. First, pyelonephritis.
That's basically a bacterial kidney infection. We'll use it as our main example for elimination issues.
Got it. Glomerulonephritis, or GN.
That one's different. It's sudden inflammation, usually triggered by an overactive immune response right in the kidneys filters.
Okay. And nephrotic syndrome.
Think massive protein loss. The kidneys just start dumping protein into the urine like crazy.
Wow. And lastly, hydronephrosis.
That's when the kidney swells up, gets abnormally large because urine outflow is blocked somewhere down the line.
Kind of.
Dangerous stuff.
All right, let's dive into that first one, pyelonephritis. It's a serious infection, but understanding the risk factors is really where prevention starts, right?
Absolutely. Pathophysiology-wise, pyelonephritis is almost always an ascending infection, meaning the bacteria start lower down, often in the bladder, and they travel up the ureters into the kidney itself.
And there are two types.
Right. Acute pyelonephritis is the active infection. You've got inflammation, maybe even abscesses forming. It's nasty. Then there's chronic pyelonephritis, which is usually the result of repeated infections. This leads to scarring, fibrosis, and the kidney tissue actually shrinks, losing its ability to filter properly over time.
And what helps those bacteria climb up?
A key mechanism is reflux. That's the backward flow of urine. Instead of going down and out, urine flows back up, carrying bacteria with it.
So who's most at risk for this? What sets the stage?
Well, several things. Urinary stasis is a big one. Any situation where urine just sits in the bladder for too long, think prolonged bed rest, for example.
Obstructions too, I imagine, like stones.
Definitely. Kidney stones, tumors, even scar tissue can block flow and cause stasis or reflux. Prostate enlargement in men is a common cause of reflux. Also, conditions that reduce bladder tone, like diabetic neuropathy or spinal cord injuries.
You also mentioned something less obvious.
Yeah.
NSA type.
Yes, long-term or high-dose use of NSAIDs. It's not a direct infection cause, but they can damage the kidney papillae, leading to scarring and reflux, which then makes infection easier. As for the bugs themselves, E. coli is the usual suspect out in the community, but in the hospital, you're more likely to see things like Enterococcus fecalis.
Okay, so how does this look clinically? Acute pyelonephritis sounds dramatic.
It is. Patients get hit hard. High fever, chills, their heart rate and breathing speed up, tachycardia, tachypnea. They often have severe pain in their flank, back, or loin area. Nausea and vomiting are common too. And of course, those classic urinary symptoms, burning, urgency, frequency.
But the key sign you mentioned.
The absolute must-not-miss sign is CVA tenderness.
And remind us what that is.
Right, so CVA stands for costovertebral angle. It's that spot on the back just below the ribs over the kidney. If you gently tap or percuss there and the patient nearly jumps off the table from sharp pain, that's CVA tenderness, it screams kidney inflammation.
Okay, that's acute. What about chronic pyelonephritis? You said it's more subtle.
Much more subtle, and that's what makes it insidious. It often presents as new or worsening hypertension. Patients might notice they have to get up at night to urinate. That's nocturia, because the damaged kidneys can't concentrate urine well anymore. Over time, they also tend to develop hyperkalemia, high potassium, and metabolic acidosis.
So diagnostics start with a urine test.
Always. Urinalysis is foundational. You'll look for positive leukocyte esterase and nitrites, which suggest infection, plus you'll see white blood cells and bacteria under the microscope. Then you send it for culture and sensitivity to know exactly what bacteria you're fighting and what antibiotics will work.
And blood tests, imaging.
Yep, blood tests will show an elevated white blood cell count, maybe high C-reactive protein indicating inflammation. And we monitor kidney function closely with BUN, creatinine, and estimated GFR. Imaging like a KUB X-ray or a CT scan helps us see the kidney structure and look for any obstructions like stones or abscesses.
Management-wise, what are the top priorities for nursing?
Two main things: managing the pain and doing everything possible to prevent it from progressing to chronic kidney disease, or CKD.
For pain, you mentioned avoiding NSAIDs.
Yes, absolutely. Acetaminophen is preferred. NSAIDs interfere with the kidney's own blood flow regulation system, specifically prostaglandin synthesis. The kidneys need those prostaglandins to keep blood flowing properly, especially if blood pressure dips. Blocking them with NSAIDs can actually risk causing further kidney injury. So acetaminophen first, maybe short-term opioids if the pain is severe.
Makes sense. And infection control.
Broad-spectrum antibiotics right away, then switch to a more targeted drug once the culture results are back. And you really have to stress completing the entire antibiotic course, even if they feel better. Fluids are important to encourage at least 2 liters a day unless there's a reason not to, like heart failure, and make sure they get enough calories for healing.
What if there's a structural problem causing the infections?
Then surgery might be needed, maybe a pyelolithotomy to remove a stone, or a ureteroplasty to fix a structural issue causing reflux. In really severe recurrent cases that don't respond to anything else, a nephrectomy, removing the kidney, might be the last resort.
Okay, so that covers bacteria causing trouble. Now let's switch gears to the immune system attacking the kidneys. Glomerulonephritis, or GN, is where we start.
Right. With acute GN, the problem is an over-the-top immune response that damages the glomeruli, those tiny filters in the kidney. It usually pops up about 10 days after an infection somewhere else in the body.
Like strep throat.
Exactly. Group A beta hemolytic strep is a common trigger. Or sometimes viral infections like hepatitis B or C.
So when you're assessing a patient, what clues point towards acute GN?
You'd ask about recent infections, definitely. Then look for signs of sudden fluid overload. Edema is a big one, especially puffy face and eyelids. Listen for crackles in the lungs, maybe an S3 heart sound. Check for neck vein distension. Hypertension is almost always present. And the urine. That's a major clue.
The color change.
Yes, patients often describe it as smoky, reddish-brown, or even cola-colored. That's from blood and protein leaking through the damaged filters.
And the labs confirm this.
Yep. Urinalysis shows hematuria, blood, and proteinuria, protein, often up to 3 grams over 24 hours. And critically, the GFR, the measure of kidney function, will be decreased.
How do we manage this? It sounds serious.
It is. Management focuses on controlling the consequences. That means strict fluid restriction, usually calculated based on their 24-hour urine output, plus about 500–600 millibars for insensible losses. And sodium restriction is vital to manage the fluid overload and hypertension. We treat the underlying infection if it's still active, maybe with antibiotics, and sometimes we use corticosteroids or other drugs to suppress that damaging immune response.
Okay, now related but distinct is nephrotic syndrome. You said the key here is massive protein loss.
Precisely. If acute GN is like small holes in the filter, nephrotic syndrome is like the filter's been blown wide open. We define it as losing more than 3.5 grams of protein in the urine over 24 hours. This huge loss of protein, especially albumin, leads to very low albumin levels in the blood, hypoalbuminemia.
And what does that look like clinically?
The low albumin causes massive edema, really generalized swelling, often starting in the face and around the eyes. They also develop hyperlipidemia, high levels of fats in the blood. And here's a really critical point.
Go on.
Patients with nephrotic syndrome are paradoxically at risk for both increased clotting and increased bleeding.
Wait, both? How does that work?
It seems counterintuitive, right? But the damaged kidneys leak out proteins that normally prevent clotting, like antithrombin III, so they're prone to forming clots, like DVTs or pulmonary emboli. At the same time, liver function can be altered, and other clotting factors might be deficient, increasing bleeding risk. It's a tricky balance, and you have to watch for both.
That is a vital point. Okay, one more in this category, nephrosclerosis. This one sounds more like wear and tear.
It is, essentially. It's a degenerative disease where the small blood vessels inside the kidneys thicken and narrow. This is usually caused by long-term hypertension, atherosclerosis, or diabetes. The narrowed vessels mean less blood flow, causing chronic hypoxia, oxygen starvation in the kidney tissue. Over time, this damages and scars the kidneys.
And management.
It's almost entirely focused on aggressively controlling the underlying cause, especially blood pressure. The target is usually strict, like less than 30–80 mmHg. ACE inhibitors are often the drugs of choice. Controlling BP is really the only way we have right now to slow down that steady march towards end-stage kidney disease.
All right, segment 3. Let's look at some other causes, starting with a genetic one. Polycystic kidney disease, or PKD.
Right. PKD is usually inherited, most commonly in an autosomal dominant pattern. What happens is cysts, like clusters of grapes, just start growing all over the kidneys relentlessly. They get huge. We're talking kidneys weighing up to 10 pounds each, maybe the size of a football. This massive enlargement compresses the surrounding kidney tissue and blood vessels. That compression activates the renin-angiotensin system, which drives up blood pressure, often leading to severe, hard-to-treat hypertension.
And the problems aren't just in the kidneys, are they?
No, that's a crucial point. People with PKD have a higher risk of developing brain aneurysms. They also have increased rates of heart valve problems, particularly mitral valve prolapse, and they're more prone to kidney stones as well. It's systemic.
What's usually the first symptom?
Often, it's pain. It might be a dull ache from the kidneys being stretched, or sharp pain if a cyst ruptures or bleeds. But an early symptom, often missed, is nocturia, having to urinate frequently at night. That happens because the cysts interfere with the kidney's ability to concentrate urine.
Is there a cure?
Unfortunately, no cure yet. So management is all about slowing progression and managing symptoms. Aggressive blood pressure control is paramount again, that target of less than 30/80. Pain control uses acetaminophen or sometimes opioids. But a big safety point here, avoid NSAIDs and aspirin,
Why is that?
because they can reduce blood flow to the already compromised kidneys, and they increase the risk of bleeding, which is already higher with those fragile cysts. And because it's genetic, referring the patient and family for genetic counseling is really important.
Okay, shifting from internal growth to external blockage, hydronephrosis and hydrureter.
Yeah, this is purely a plumbing problem.
Yeah.
Something, a stone, a tumor, a stricture, or narrowing blocks the outflow of urine. Urine backs up behind the blockage, causing the kidney itself to swell, hydronephrosis, or the ureter to swell, hydrureter.
And this is urgent.
Extremely urgent. That backup pressure can cause permanent kidney damage very quickly, sometimes in less than 48 hours. The absolute priority is to relieve the obstruction immediately.
How do you do that?
It depends on the cause, but options include surgery or radiology interventions. Maybe removing a stone or placing a ureteral stent, a tiny tube that props the ureter open and bypasses the blockage. If the obstruction can't be corrected easily, a nephrostomy might be necessary.
What's that involved?
That's where a tube is inserted directly through the skin on the back, right into the kidney, to drain urine externally into a bag.
Okay, and you mentioned a critical safety point with nephrostomy tubes.
Yes, a huge nursing safety priority. After a nephrostomy tube is placed, you must monitor the drainage output hourly. If the drainage suddenly slows down or stops completely, especially if the patient complains of new back pain, you have to suspect the tube is blocked or has become dislodged.
And what do you do?
Notify the surgeon immediately. Pressure is building up again inside the kidney, and that needs to be fixed fast. Also, another pre-procedure check. Make sure their clotting studies, like INR, are normal or corrected beforehand, because you're putting a tube near major blood vessels.
Good point. Lastly in this section, renovascular disease, RAS.
This is narrowing of the main renal artery, the big vessel supplying blood to the kidney. This drastically reduces blood flow. The classic sign is often the sudden onset of severe, difficult-to-control high blood pressure, especially in someone over, say, 40 or 50 who didn't have high blood pressure before.
Management.
Again, blood pressure control is key, often with ACE inhibitors, and then trying to restore blood flow to the kidney, either with endovascular procedures like stenting the artery open or sometimes bypass surgery.
All right, final segment. Let's touch on kidney cancer and trauma, starting with renal cell carcinoma, RCC.
RCC is the most common type of kidney cancer in adults. It's known for causing some weird systemic effects called paraneoplastic syndromes. Basically, the tumor starts making hormones it shouldn't.
Like what?
Well, paradoxically, it can cause either anemia or erythrocytosis, too many red blood cells, because it might mess with erythropoietin production. It can also cause hypercalcemia, high calcium, and hypertension, because it might pump out extra renin.
Is there a typical presentation?
There's a classic triad often described: flank pain, hematuria, which might be visible blood or just cola-colored urine, and a palpable mass in the abdomen. But honestly, that triad often means the disease is already pretty advanced. Many RCCs are found, incidentally, now on scans done for other reasons.
And the main treatment?
Usually surgery, a nephrectomy, removing the kidney. These tumors can be very vascular, bleed a lot. So sometimes before the main surgery, the surgeon will perform arterial embolization, basically blocking the arteries feeding the tumor to minimize blood loss during the removal.
What are the big post-op concerns after a nephrectomy?
Two major things to watch for. Hemorrhage, obviously, and adrenal insufficiency. The adrenal gland sits right on top of the kidney, so it can sometimes be affected or removed during the surgery. Both hemorrhage and adrenal insufficiency can present with hypotension and decreased urine output. So hourly urine output monitoring is critical. You want to see more than 0.5 milliliters per kilogram per hour.
Okay, finally, kidney trauma, usually from accidents.
Yeah, most often blunt trauma, like car crashes, falls, or sports injuries. The injuries are graded on a scale from 1, which is just bruising, up to 5, which involves shattering of the kidney or tearing of the major blood vessels.
For initial management focuses on.
Preventing shock. So aggressive fluid resuscitation and very close vital sign monitoring maybe every 5 to 15 minutes initially.
And you highlighted a specific safety alert here.
Yes, extremely important, especially in an emergency or trauma setting. If you see any blood at the urethral opening, do not try to insert a urinary catheter.
Why not?
Because that blood could indicate a urethral injury or even a bladder rupture. Trying to force a catheter in could make a partial tear into a complete one, causing much more damage. You need to wait for a urologist to evaluate before attempting catheterization.
Makes sense. And severe trauma.
Grade 5 injuries, the really severe ones, usually require emergency nephrectomy. And just a prevention point, always stress wearing seatbelts. And if someone only has one kidney, they should generally avoid contact sports.
Wow, okay. We've covered a lot of ground. So pulling it all together, what's the big picture takeaway for our listeners navigating all these kidney disorders?
Well, we've seen everything from infections like pyelonephritis to genetic issues like PKD, but the common thread is how central the kidney is to balancing fluid, electrolytes, waste, and even acid-base status. Everything is interconnected.
And the consistent themes for management.
Vigilance is key. We saw how critical controlling blood pressure is across almost all these conditions, infectious, degenerative, genetic. Recognizing those key assessment findings, like the sharp CVA tenderness in acute pyelonephritis versus the subtle signs of chronic disease, and understanding the immediate life-saving importance of things like monitoring nephrostomy drainage, that's fundamental nursing.
So let's synthesize this with a quick scenario. Imagine a patient comes in, history of diabetes, maybe had kidney stones before, takes NSAIDs regularly for arthritis. Now they present with fever, flank pain, and their BUN and creatinine are sky high. This is where all those risk factors converge, right?
Exactly. It's a perfect storm highlighting how seemingly separate issues, diabetes, stones, medication use, can create an acute kidney crisis.
So thinking back on everything we discussed, if you encountered that patient, what clue, what piece of data would you prioritize first to guide your immediate actions? Is it the flank pain suggesting inflammation, the NSAID history pointing to a potential drug-induced injury, or those severely elevated kidney function tests showing how much function is already lost? Where do you start?
And that is the kind of critical thinking and synthesis this knowledge allows. Moving beyond just knowing the facts to applying them under pressure. Keep practicing that synthesis.
Absolutely. Well, thank you for joining us on this deep dive into these crucial kidney care concepts. Keep learning, keep synthesizing,